Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. Today I'm joined by my good friend and colleague and who I call the legend in retina, Dr. David Boyer, Clinical Professor of Ophthalmology at the University of Southern California Keck School of Medicine and Senior Partner at Retina Vitreous Associates Medical Group in Los Angeles. Welcome, David.
Thank you, Arshad. Good to be here with you.
We are so excited today to have you because, one person that comes in mind to me that has been involved in all the latest and greatest innovation in the retina for past several decades is you. And not only that, you continue to be involved in all the advancement that we are working in our field to push, in terms of having better treatment. So no better person than you, David, to be here. And today we will be discussing new mechanism of action and clinical data that supports their use in retinal diseases. But just like every other guest we have, before we get started, we ask some personal questions so that our audience can get to know you better. So the first question I have for you, David, is what inspired you? How did you end up doing what you do, being a vitreoretinal specialist?
Well, I actually ended up probably the back way in. I originally started to go into ear, nose, and throat. Actually, I wanted to be a plastic surgeon. And the rotation I was on was exciting, but they had a lot of cancer. And my dad died of mesothelioma. So one of the things that I did on the ear, nose, and throat rotation was I worked with somebody who did a lot of cancer, and it just wasn't the right time. So I went into ophthalmology and almost backed out until I went to the retina rotation. And then I felt this is like part of medicine. I really felt very far removed from actual medicine until I did retina. And retina brought me back into this feeling that I was really a doctor, and the diseases that I had to know and all about the diseases made me go into retina.
No, I think that's a very interesting route. Were there any mentors or anybody that inspired you to do retina, or it was just because it's such a great connection from systemic diseases to the retina that it's very interesting, obviously.
It's very interesting because the first job offer I ever had was in ear, nose, and throat by the people I rotated with wanted me to go into ear, nose, and throat. They guaranteed me the fellowship, the residency, and to go into their office. But when I rotated in retina, it was really the senior residents when I did an extra rotation that really inspired me. And going to retina clinic was so exciting to see CM. At that time, we were seeing CMV retinitis. We were seeing diabetic patients. We were seeing all kinds of diseases that I could correlate with. And I really felt very excited about doing it. So I think it was my experience in a separate rotation that I did in ophthalmology that the retina division actually inspired me to do this.
No, that is excellent to hear. So tell us a little bit about yourself. What's your favorite hobby?
My favorite hobby is being with my family anywhere. I like to travel, and I love to be with my family and share these experiences. I love to be with my friends, you being one of them, and spending time and just enjoying things. I used to play tennis, but I don't play tennis anymore, and I don't play golf. So I don't think I have a hobby that people would relate to, but I just enjoy being with very bright people like yourself and others that you know very well that inspire me.
No, you're so kind, but I got to know your wife and your son and his wife and granddaughter because of your Lifetime Achievement Award at CTS several years ago. And I tell you, you have a wonderful family and nothing better than spending family time. And that's what I try to do as much as I can. I know you travel a lot. You like to have good cuisines, also. So what is your favorite vacation spot?
I like to travel to places I've never been. I always find that exciting. I guess, if you had to list them, I think being on safari with my family was great. I think, being in the Galapagos, Machu Picchu, but everywhere I've gone with family, I always find it exciting, and I always manage to enjoy every moment that I spend. As your kids get older and you're not with them a lot. And to me, the family vacation that we have every year is extremely important to me.
No, that is so true. I think that's some good advice for younger generation, even from me too, that sometimes it gets so busy that you gotta balance, you gotta make sure that you have enough time with the family and especially on vacation. I take 2 weeks off at the end of the year and I turn my phone off as well as my computer and it's all family time. And I think it gives anxiety that you're gonna be behind on so many things, but I think it's worth it. It's very refreshing.
I think they're only young once, and you don't want to miss that opportunity. And I think that every day you spend with your family is a great day.
Words of wisdom, Dr. Boyer, you give a lot of words of wisdom about everything. And I think this is also very important for our listeners. Okay, let's get to the topic at hand. You're being through this innovation of anti-VEGF agents, lasers and whatnot. And you have been part of all of that innovation with steroids and all these treatment options that we currently have. What do you see as the most significant unmet needs in the treatment of retinal diseases currently, such as neovascular AMD, DME, and DR, with current therapies that we have available?
Well, as you indicated, we've come a long way since I originally started in ophthalmology. We've made great strides, but despite the great strides we've made, there are still a large number of patients that don't get the full response that we'd like to see. I mean, diabetes is probably a good example. You get 40% of patients that do phenomenally well, gain 12, 14 letters. And then you get a group of maybe 30% that gain 6 letters, and you get another group that doesn't gain hardly anything. So I think that there's an unmet need in DME and in neovascular AMD of patients who still have active disease on the table, even despite even monthly injections in some cases. So I think that we need new modes of action to be able to do this. I mean, we're starting to go longer acting. As you're well aware, you're involved in almost all these gene therapy trials and some of the TKIs that may last longer, but we still have a large group of patients that you just can't dry out. If we had other modes of action, that we'd be able to dry these people out and perhaps get better vision overall for all these patients.
No, I think very well said. I think, we are so lucky to have all the treatment options that are available, but clearly we can do better. And I think as a field, we've been trying to do better. And, we had the approval of faricimab a couple of years ago that targets both VEGF-A and Ang2. And that was the first time we have had additional MOA. Obviously, this is a bispecific antibody that's one molecule with two targets. But can you discuss some of the significance of dual mechanism because Ang2 inhibition has been studied in other trials besides faricimab too as a co-formulation, and we did see some signals of better drying, better diabetic retinopathy, severity score regression. So, what are your thoughts on this dual mechanism and its potential impact on treatment outcomes?
Well, I think that we're seeing now this dual action does play a role, even in drugs that have not gone forward, like the Zavacumab. In the early portion of the trial, you actually saw separation. You saw better drying. You're finding that you're able to dry patients out faster, hopefully leading to a better vision long term. You may be able to extend them a little longer. We know that Ang1 and the Tie2 together in a normal circumstance, keep the permeability under control. It's when the Ang2, which comes about in pathologic conditions, is activated that we start to get these areas of leakage, inflammation, fibrosis. So I think there's some early evidence that a combination and blocking, the Ang2 will reduce leakage. Number one, may reduce fibrosis. There's some data that shows that even epiretinal membranes may be reduced. So I think that it's a step in the right direction. A lot of companies are now adding that into their armamentarium when they're doing dual mechanism treatments. And I think it's real. I think that there is something there. Will it give us better vision? I think that's the question that we really have to answer long term. It may extend us a little bit, but again, we've been fortunate to have very, very good treatments. But I think this is a step in the right direction of trying to get another mode of action to help us reduce inflammation, fibrosis, and fluid leakage.
No, I agree with you. I think it's always great to have additional mechanism of action. Obviously, we have not seen the vision superiority with Ang2 inhibition in combination. But clearly, as you said, we have seen, greater reduction in fluid, faster drying. We have looked at, hyperreflective foci, intraretinal fluid, and of course macular leakage. We saw that less macular leakage with the dual inhibition compared to aflibercept in the clinical trial. So I think it's exciting, extending durability. Obviously the trials with faricimab looked up to 16 week of dosing, which is something obviously was done for the first time compared to up to 12 weeks of dosing that was seen with brolucizumab. So yeah, I mean, I think having this as a tool in our toolbox has been great in terms of whether you're starting naive patients on it or whether you're switching, persistent disease patient. But I think, David, you mentioned a really good point is we have not been able to achieve better vision. Why do you think that is? I mean, we are drying the retina better, but at the end of the day, we are not seeing better vision.
Well, I think there's several things. You and I have to look at and what's causing us not to get better vision. We have atrophy that is associated with long-term fibrosis. I think, that we realize, I think today that the earlier we can catch the patients, the better vision they'll have at the end. I mean, one study showed 70% of the time you don't lose one letter if you treat. If you do these trials longer and continue the treatment, I think that you may get better results. But there are other things involved. You've got VEGF-C, which upregulates when you've treated, constantly with anti-VEGF-A treatment. We've seen that in cancer patients, and VEGF-C may play a role. That may be part of the reason that we don't see a marked decrease in all patients with fluid. So there are other mechanisms involved that I think are being investigated very, very clearly to try to help us dry these patients out and perhaps get better vision long term.
The other point is that when we look at trials, we look at averages, right? And we have great drugs with anti-VEGF-A, but I think if you looked at some of the subset of patients, right, with persistent fluid and other things, we may be able to see a vision benefit. But of course, in overall, we have not seen that. So you mentioned inhibition of VEGF-C and of course VEGF-D. There's a program, OPT-302 or sozinibercept, that blocks both VEGF-C and VEGF-D, and you've been involved with it since the early stages of phase one. You're a co-author on all the papers. Tell us a little bit about that program and the data to date and what to expect in the future from that program. Obviously, this is a dual injection, so this goes on top of your current standard of care. And tell us a little bit about how do you think it fits in the future when hopefully if it's approved.
Well, I hope it's approved. I think that it makes sense. In cancer patients, they've seen an upregulation of VEGF-C after continuous injections of anti-VEGF or VEGF-A. We all have seen patients that develop a tachyphylaxis. They start to reduce the response, and we treat them, let's say, every 2 months, and they're doing fine, and they come in every 8 weeks, and then suddenly they have fluid at 8 weeks, and now you drop them to 6 weeks, and you're going, why is that patient? I gave him the same dose. I gave him, and I think that we're underestimating what the increase in VEGF-C and VEGF-D, but mainly VEGF-C does. And when you looked at the studies that have been done, the combination studies in phase two really showed about a 3.5 letter improvement over constant anti-VEGF-A treatment. So if you compare it to current therapies, you're actually getting much, much better. And also the 10-line, or more letter gainers was much higher in the treated group with OP302, about 70% versus about 58% in the patients that were treated conventionally. So to me, it makes sense that there is a component of VEGF-C that we just aren't treating with our current treatments, VEGF-A treatments. I think that people are starting to realize this. So I think a number of people are adding on to these bispecifics that, we can discuss if you want, that they're adding this in because I think that there is something there. And I think that we're not going to see the tachyphylaxis, and I think we're going to see a slight improvement of vision. Perhaps this is part of the reason we don't dry these patients out totally.
I think those are excellent points. I think it is clearly exciting to go beyond in terms of visual acuity because, as you said earlier, we have not seen better vision than what we saw with bevacizumab and ranibizumab, a long time ago. And I think our field has struggled to get better vision. And I think this is important here because this is our chance to get better vision. And I think, as you said, it's a validated pathway. So, obviously the phase three Coast and Shore studies are ongoing, and we'll have data next year to see if those trials meet the endpoint. Safety is important, David, when you look at new treatment option, because we're all very sensitive because we have great treatment options currently. Was any new safety signals seen in the phase 2B trial that you were talking about?
No, not at all. It was very well tolerated. There were really no additional safety signals with adding the additional drug. There was no glaucoma. There was no signs of vasculitis or any of the things that we look for. I mean, we both know that we had a wonderful drying agent in the form of brolucizumab, but unfortunately, due to the side effect profile, it's not well used, but it dried patients out better than anything I've seen in the past.
And then last question, David, on the topic, two injections, right? 50 microliters of anti-VEGF-A, whether you're using any of the currently approved agent or off-label or biosimilar, and then sozinibercept on top. Do you feel like that's challenging, or it's easily adaptable, given that now we're giving 100 microliters for geographic atrophy injections?
I don't think it's a major drawback. I mean, when you look back at, when we first started with Macogen, you were giving 0.09, and there were no evidence at all of any increased pressure problems long term. The patient's pressures were well tolerated. I think, if you have a patient with glaucoma, you may need to wait a few minutes before you inject them. But a normal patient, you can give, zero point 0.1 ml and be fine. I don't think that's going to be a problem. They're numbed already, so you really are just talking about one additional injection. If my patients could get 4 letters, I think they would be willing to take the additional injection because they're already numb at that point. So I don't think it would be a major problem for me.
No, I agree with you completely. We are part of the phase two and phase three studies, and initially I thought there would be pushback from patients. But if when we talk about better vision, I think that's what we are in the business for, and that's what patients are here for. I think they are very open to get the second injection. So I agree with you. I think easily adaptable if we have the data that's positive. So we'll find that out next year. And you mentioned, tri-specifics, bispecifics. There's a lot going on, obviously in early stage where companies are trying to do VEGF-A, Ang-2, or IL-6, or Ang-2 and VEGF-C. So we'll see how that pans out. So David, we are coming to the close of this podcast. So we again will ask you some personal questions so the audience can get to know you better. You've been in practice for a while. How long have you been practicing?
I've been practicing for millenniums, but I've been doing retina for about let's see, it's 44 years.
Oh my God. Yeah. You're truly a legend, I tell you. 44 years, and your energy and your enthusiasm is very infectious for all of us. And it's a great learning for everybody how to have their amazing career and still be so excited about, taking care of patients, which you love, and on top being involved with everything else. So David, what career achievement are you most proud of?
I think that what's really re-energized me is being around and participating in these scientific advisory boards with you and other friends of mine. I find that when a drug makes it to fruition and is used, I feel, similar to the person, instead of, going to my clinic and fishing for one fish at a time, that I've actually taught a bunch of people how to fish. These people now can use this drug. And I feel very good about that. I mean, I think that whatever little bit I contribute to that drug making it to the market, whether it be in the SAB and trying to get a good study going or in trying to enroll patients. I think that to me has been the most exciting part of my practice. I think I enjoy that more than almost anything.
No, I totally agree with you. When you are involved with bringing a new treatment, you can make impact globally, right? You have in your career with essentially all the current available treatments we have, thanks to you and many others who helped us. I totally agree with you. The satisfaction that you are part of early stage trial design or or the trial, and then now you're 10 years later, right? Usually you take that drug and it's approved and you're using it in your clinic. It's a very satisfying feeling. So that's something for our younger doctors to learn, to be engaged and involved in this, because I think it's something that gives me a lot of excitement, and obviously looking up to you at everything I do, how you have really contributed to all the greatest treatments to preserve vision for our patients. And I know you're still going strong, David. So tell us, how do you want to be remembered by your colleagues once you retire? I'll ask you, and then I'll tell you how I will remember you, obviously. But I don't want you to retire. That's not what you're saying. We want you to practice for a long time. But once that kind of time comes, how do you want to be remembered?
I would like people to say that I was an honest, hardworking physician that tried to do the best for the patient. I don't have any grandiose ideas of how people will remember me. The friends I've made along the way are the most important thing to me, and much more important than anything else. And I just want the patients to know I tried the best for them. Hopefully, it worked most of the time. And I want to go away being an honest physician. I didn't do anything I didn't need to do. That's probably, what I really want to be remembered as.
Well, I think those are great points, but I'll tell you what I see in you, and I think that's something that's very special, is you have achieved so much in your career, but you always stay humble, and you always are so kind to your colleagues. You're very collaborative, and you're very nice to everybody, whether it's a younger doctor or an older doctor. You really treat everybody with respect. So I think that's something people can learn from you, is that it's all about treating everybody well, and you have done a great job with that. And collaboration, and really giving the limelight to everybody and just not asking for limelight to yourself. I think that's something I've learned from you, and we all inspire to be like you. David, thank you, Dr. David Boyer, for excellent discussion, and thank you to the audience for listening. Please remember to take the post-test and evaluation to receive CME credit, and to tune in for additional episodes within the podcast series. David Boyer, thanks again for being here with us.
Arshad, thank you very much.